So I've just been reminded that this is the 25th Palliative Bites since we started this series of lectures during COVID. So this is the silver anniversary Palliative Bite. And I'm delighted to introduce Dr. Sharon Chadwick, who's consultant in palliative medicine at the Hospice of St. Francis in Berkhamsted, where I used to work with Sharon, and at Watford General Hospital. She has an amazing experience with heart failure and has developed services in heart failure, the management of heart failure in the palliative phase, and she's going to share that with us. So just before we start, just a few ground rules. While Sharon is talking, we're going to keep you all on mute or mute yourselves. Do save up questions in the chat box as Sharon's going. We definitely hope to have 10 to 15 minutes at the end where we can ask Sharon some questions. I've definitely got a few. We are recording this session, I believe, so that the recording will be available afterwards and we can send the link. And we are planning to upload some of our recordings of these lectures on the Michael Sobel website. And just to remind you that if you've got your diary, the next Palliative Bites is on the 12th of October, which I'll say at the end again, which is it's going to be a really interesting session with Georgina Murphy-Jones from London Ambulance Service talking about how LAS are increasingly interacting with patients who want to be cared for at home in the palliative phase of life. And she'll reflect on some of the work they've been doing across London and particularly some of the work we've been doing with them in Hillingdon. So I think, Sharon, it's over to you. Hopefully you can all see Sharon's first slide. And thank you, Sharon, for being here.
Thank you very much, Ross. Can you all hear me okay? Yeah, fabulous. Well, thank you for inviting me to speak. I have been working for some time in heart failure. I was first asked to get involved when I left Hempstead Hospital, which was still open at the time, 20 years ago. I was approached by one of the consultant cardiologists who'd heard that I was going to work in palliative care and said, I really need your help with my breathless heart failure patients. And I've been developing an interest and working with an ever-increasing team since then. The objective for this session is that I hope that by the end of it, you'll feel a bit more confident in managing end-stage heart failure, but also understanding the complexities of managing it. You'll feel more able to address symptom control needs and be more proactive in discussing advanced care planning, which is absolutely vital for these patients, but also to be aware of the ethical dilemmas that might arise. As ever, in palliative care, we're really focusing on what is right for the individual patient and family, and there is no doubt that not one size fits all. We need to really consider how best to foster relationships locally to provide the best care for patients and families. And I think we're really lucky in West Hertfordshire because we have got an amazing community heart failure team, and I work with them very closely as well as the hospital team. So actually we have a great service in West Hertfordshire, but also knowing who to ask for help if you have questions or are running into trouble. Anyone who has heard me speak about heart failure before will have seen this slide. So this is the typical course of heart failure with diagnosis at point 1, and then at point 2, sort of between point 1 and point 2 is where typically the heart failure nurses will take responsibility for introducing the 4 pillars of medication for heart failure and titrating that up to the maximum tolerated doses. We then hopefully have that period of stability between the double lines in phase 2 before the patients tend to become more unstable and have episodes of increasingly frequent fluid overload and renal impairment. Then sadly they become less responsive to diuretics, or it becomes more difficult to manage that because of their renal impairment. and then they become much more unwell, much more dependent, but they can live for long periods of time in that very dependent symptomatic state before finally they die. So what might make us think that a heart failure patient has...
Sharon,
Yeah.
sorry to interrupt, just to say that I can hear you well enough, but in our seminar room, you are quite quiet. I don't know whether there's any way you can turn up the microphone on your computer.
I don't think that there is.
Can everybody else on their laptops hear Sharon clearly? Put your thumbs up. Yeah, so I think must be our end. Okay, don't worry, carry on.
That's okay. So what I have to say, and I think I said this again on a later slide, prognosticating heart failure is the most difficult disease to prognosticate. It's worse than COPD. It's clearly much more difficult than cancers, because people go through this cycle of decompensation, fluid overload, offloading, then they get a bit of renal impairment, and then they kind of come back to a more stable position again. And that happens repeatedly. And the problem with that is that patients and families think the patient is immortal and is never going to die. And, you know, you're trying to have conversations around advanced care planning, and they'll say, well, we've been here before. We've been told they're going to die before. So I think we have to be quite careful with the language. But the key indicators of a likely poor prognosis would obviously be increased age, patients dependent for more than 3 activities of daily living, cardiac cachexia, which is sometimes quite difficult to see because of the fluid overload, resistant hyponatremia, a serum albumin less than 25. Well, I would say the vast majority of patients that I look after have got an albumin of less than 20. BNP of greater than 400, that's in old units, so you need to make sure that you've got the units correct. If they've got a device in, if they are receiving multiple shocks from a defibrillator, and co-morbidities, especially cancer. And I think, I would say, all of my outpatients now either have heart failure or they have interstitial lung disease. The patients with heart failure have a list of diagnoses as long as you're on. You know, we're not talking about, patients so rarely have an isolated diagnosis of heart failure. They're almost always in renal failure, they're almost always diabetic, they have lots of other things going on. And when I write my letters, and Ros is a really big fan of my very long letters, aren't you, Ros? The first page is often just a list of diagnoses and drugs, and that's 2 columns of drugs and 2 columns of diagnoses. So that's my excuse, and I'm sticking with it. Okay, so I am now not able to move. Okay, so we also know that patients with advanced heart failure are likely to have multiple admissions in the last year of life. And as I alluded to earlier, they're walking a real tightrope between renal impairment and fluid overload. Comorbidities and polypharmacy add increasing complexity, and that's why palliative care in heart failure is so important, because we do look at patients as a whole. We don't just see them as a heart with their heart symptoms. It's a case of looking at them as a whole in the context of their illnesses and their family and their function. So this is a list of potential problems for the individual patient. So left ventricular failure, angina, atrial fibrillation, COPD, peripheral vascular disease, impaired renal function, diabetes, cerebrovascular disease, osteoarthritis, depression, falls, and cancer. And there's more. Just to, as an aside, I can give you an example of a patient that I'm looking after with the community heart failure team in the community at the moment, who had lymphoma as a teenager, had a splenectomy and radiotherapy and chemotherapy for that, went on to develop heart failure, had a metallic aortic valve put in. Then she developed diabetes and renal impairment with severe heart failure. She subsequently went on to have cataracts. She's got severe lymphedema, managed to get one of her cataracts operated on, and as a result of that, she's just been diagnosed as having giant cell arthritis. And was a bit horrified to find out this woman who has severely impaired renal function and very unstable diabetes. And the rheumatologists were planning to treat her in ambulatory care with colostomy beds. And I'm sure you can imagine how quickly I stepped in to say, I really think she needs to go into hospital for this. So really, really complex patients. So actually we need to be, certainly as palliative care physicians, we need to be on top of our game in terms of managing general medical issues. And this particular lady is only in her 60s. So what do the patients suffer from? Well, fatigue, dizziness, breathlessness, peripheral edema, nausea, constipation, immobility, constipation again, because it's such a big problem, pain, low mood, and social isolation. And of course, postural drop is a really big problem when we're trying to get that balance right between fluid overload and using diuretics, and also maintaining the prognostic medication for patients. So the 4 pillars that I mentioned earlier, these are the things that we try to get on board for every heart failure patient. Well, in the old days, that was an ACE inhibitor. Then ACE inhibitors, I mean, they're still used, and sometimes we use the angiotensin receptor blockers, but Entresto is the way to go, really. So what we try to do now is, for patients who are on an ACE inhibitor, we try to replace that with Entresto. So Entresto is an ARB with the neprilysin inhibitor, and that increases the level of vasoactive substances, which helps to counteract the neurohormonal overactivation that makes patients have vasoconstriction, sodium retention, and other things that in a normal person would be a good way of maintaining cardiac output and blood pressure, but actually isn't helpful in heart failure. Then we have the mineralocorticoid receptor antagonists, including spironolactone and eplerenone, beta blockers, and the new kids on the block, the SGLT2 inhibitors that were first developed for use in diabetes, but now seem to have replaced statins as the drug of choice for almost every illness that everybody has on the planet. So they're really good drugs, but have to be used carefully, especially in older people who might be incontinent and having recurrent urinary tract infections, because the way that they work is they actually make us leak sugar out into the urine, so that increases the risk of not only candidal infections around the groin and the genitals, but also makes the risk of urinary infections much higher. So studies have shown that whatever the etiology, and there are multiple etiologies that cause heart failure, there is a high symptom burden, and we know that the quality of life can be very poor for both patients and carers. There is an inevitable deterioration, even though patients often say to us, oh, thank goodness I've got heart failure, I thought I got cancer. Actually, that's not such a good diagnosis to have after all, which they soon recognise. And towards the end of life, they do have more frequent hospital admissions, either due to fluid overload or acute on chronic renal failure in the final stages of the disease. So non-drug management, and Roz and I were just mentioning this before I started. The number one thing is salt restriction. Okay? There is nothing more important. I will talk to patients and tell them that salt is their poison. Okay, this is not, oh, I don't add salt at the table. Well, that's jolly good, excellent. I don't even cook with salt. That's jolly good. Well, I do like a bacon sandwich. And we were just sharing a memory of a young patient whose favourite food was Pringles. He used to love his Pringles and he used to love a bacon sandwich. And I had a patient last week who's under our community heart failure team who have spoken to them about low salt diets. And when I actually went through and said what a low salt diet meant, she went, oh, but I really love Marmite. And I'm like, she was drinking cups of Marmite or Bovril. I feel like, it's your decision. I'm just telling you what I know is going to make a difference. Because, of course, what happens is if they're having a high salt diet, we are then having to give them higher doses of diuretics in order to get rid of the sodium, in order to diurese them, and then we're frying their kidneys. Okay, so we've had one relatively young patient who has come into us on a regular basis for offloading. She has compromised cognition, and we've been through the whole fluid restriction, salt restriction issue with her on multiple occasions, also with her carers. But she finds it really, really difficult to be concordant with that. And so we bring her in, we fluid restrict her, and we stop the salt, and she'll lose kilos of weight just without us even having to do anything with the diuretics. It is quite extraordinary. But be aware of the range of food that means the patients should try to limit. At the end of the day, it is their choice. I'm on a mission at the moment to try and get the salt packets taken off the meal trays on the cardiology wards at Watford. I just cannot believe that they still do that. Fluid restriction, we usually fluid restrict to 1.5 litres, which is about as low as patients can go, but that has to include all fluid. So that's tea, coffee, water, soup, ice cream, sorbet, gravy, and sauces. So it's quite tough. When you think about, a cup of tea is about 200 mils, isn't it? So it's not very much at all. And the other thing is that trying to encourage them to have more of that fluid during the day and reduce their fluid intake in the evening so that they're not getting nocturia with the diuretics that they're often taking. So in terms of symptom control, obviously we need to rule out reversible non-heart failure causes, so chest infections and so on, anemia, which we'll come back to shortly. But if we have ruled everything else out and they haven't got pleural effusion or anything like that, these are the things that we can do. So firstly, we always go for the non-pharmacological measures, so fan, pacing, rehabilitation. And both for heart failure and for respiratory patients, what you often find is that they don't exercise because when they exercise, they feel breathless and that frightens them. So they exercise less. And then when they do try and walk, it makes them breathless. And so they panic and they exercise less and they become deconditioned. So we often find that cardiac rehabilitation or rehabilitation on a hospice program can be very beneficial for that. And pacing, this is more of an issue really, I think, with the respiratory patients. But I often talk to my patients about the difference between being a tortoise and a hare. If you are going to go with opioids, because I think opioids really is the way forward for managing breathlessness in heart failure, I will use benzodiazepines if I think anxiety is a huge problem, although we know that the evidence isn't there, but my view is that they probably don't select the patients who are more anxious when they prescribe benzodiazepines. So I would tend to go with opioids, but because they tend to be an elderly group of patients, often with compromised renal function, who are a bit frail and might be at risk of falling, I start really low doses. I warn them that it might not help with their breathlessness because we're being very cautious to start with. So just depending on the size of the patient, the risk of falls, and their overall frailty, I would start oral morphine liquid 1 to 2 mils 2 or 3 times daily, or if they've got an EGFR of less than 30, then I would use oxycodone 1 to 2 mils twice daily. Morphine usually is reasonably tolerated. I do warn them about the patient information leaflets that says if you're breathless, you shouldn't be using morphine. Yeah, it says more. It's more about if you've got a lung problem. So it tends to be more of an issue if we're prescribing it for breathlessness and COPD. And I always warn them about constipation and ask them to take some laxatives if that becomes an issue. In terms of leg swelling, I often feel this is more of a problem for heart failure nurses than it is for the patient. So we just have to be clear whose problem it is. And sometimes we might need to accept a degree of fluid overload and increase the diuretics, and then we need to monitor their renal function a bit more closely. I think that light compression stockings can make a real difference, not only to swollen legs, but also to postural hypotension. So it's always worth considering that. And I think that, again, the low salt, the fluid restriction can be really helpful with this. Difficulty in sleeping is often an issue. That's often because they're catnapping during the day, and so we need to put sleep hygiene measures into place and try and get some distraction going during the course of the day, if that's possible, and actively discourage people from sleeping during the course of the evening, certainly after 5 o'clock in the evening. Also, we need to screen for depression, which is very common in heart failure patients. A lot of patients have a swollen abdomen. Is this constipation? Is it ascites? Is it obesity? And we need to differentiate between those and treat what we can. My experience is that even with the MRAs, it's very difficult to shift both ascites and pleural effusions. Okay, so we can give it a go, and sometimes increasing the diuretics, the loops, and the MRAs can be helpful. But we do have to resort to doing paracentesis and pleural aspiration on some occasions. And then if we can get rid of the fluid that way, we hope to be able to maintain it by using appropriate amounts of diuretics and the other measures that we've already talked about. Confusion may become an increasing issue. Many of our patients may have undiagnosed dementia. We need to be thinking about the electrolytes, especially low sodiums, although if a patient has had a chronically low sodium, then that tends to be less of an issue. We worry about drops in sodium rather than, if a patient has a sodium of 128, but it's been 128 for the last 3 months, I'm not particularly worried about that, unless they've got a huge postural drop. If they have suddenly dropped from a sodium of 140 to 128, then you'll be much more worried about it because of the shifts of fluid in and out of the brain. Always we need to be screening for infection, especially UTIs, and especially if they're on an SGLT2 inhibitor. Just going back to sodium, sometimes, so I meet with the whole heart failure team every Thursday morning as part of our MDT, where we have heart failure consultants from the trust, and we have the whole community heart failure team present. And sometimes if we're really struggling with sodium levels and patients need higher doses of diuretics and their blood pressure can stand it, we will actually prescribe slow sodium. So that is something that we do, which is counterintuitive if you're telling patients to have a low salt diet. So I think the problem is this is part of the magic of medicine, isn't it? There's no black and white answer. It's quite unusual for us to do that, and I wouldn't be doing that without talking to a heart failure specialist. Midodrine, which is now for adrenergic agonist, can be very helpful if patients have got a severe postural drop. Fludrocortisone doesn't really cut the mustard, so we would definitely go for midodrine as our first treatment option if we can't manage it any other way. And possibly de-prescribing some of the drugs, which is quite a lot of the conversations that I will be having at the MDT about what we can stop and when. For fatigue, which is, I think, alongside peripheral edema and breathlessness, is one of the most significant symptoms in heart failure. We've spoken about sleep hygiene. I will encourage patients to have a siesta after lunch. We've spoken about rehabilitation. We all know the old adage that exercise is the best treatment for fatigue. We need to check for other reversible causes like electrolyte disturbance, anemia, hypotension, depression, nocturia, and drugs. The other thing that is quite new on the block is the use of intravenous iron in heart failure. And studies have shown that if a patient, even if they're not anemic, if they've got a ferritin of less than 100 or a serum ferritin of between 100 and 300 with transferrin saturations of less than 20%, then giving intravenous iron will reduce the risk of hospitalisation, improves the NYHA functional class, and improves quality of life and exercise capacity. So at St Francis, we have actually now set up a service for giving intravenous iron, which has been a really successful project and has meant that our heart failure referrals have increased significantly. So this shows that increase in heart failure referrals to the end of 2022. You can see a lot of those referrals came in through the IV iron service, but also we've had an increase in community referrals, but also look at the numbers that we've had coming through from medical review. And also, you know, on the inpatient unit, we've always been quite brave at trying to offload patients with intravenous diuretics, and that's remained quite steady. I would say there's rarely a week now where we don't have at least one heart failure patient on the unit. I love the concept of the Kalman gap. I think it is all about what we do in palliative care. So the Kalman gap is the gap between the expectation of the patient's function and the actual reality. So what we try to do in palliative care is to improve the reality by using medication to improve symptom control and to do rehabilitation to improve exercise capacity, but also helping the patient to come to terms with what their new level of function is. And by reducing the expectation and improving the reality, we reduce the gap between those two, the Kalman gap, and that improves quality of life. So what about us? Oh my goodness, so many symptoms, so many drugs, so many comorbidities. There are all these devices that they have that we don't really know very much about. We don't even know where to start. We don't feel like we know enough. We worry about making things worse. We don't want to upset our colleagues who might have started the drugs. And there's always new drugs and new interventions. It's quite difficult to keep up. And I absolutely get that. And I have to say, I learn something new pretty much every week in that heart failure MDT because there's so much going on. But help is at hand. Hopefully, most of you will have access to a community heart failure team. In Northwest Hertfordshire, actually in West Hertfordshire, until recently, it's probably about 2 years now, but they were only commissioned to provide support for patients with left ventricular systolic dysfunction, but now they're able to support patients with valvular heart failure. HFpEF, which is heart failure with preserved ejection fraction, as opposed to HFrEF, which is heart failure with reduced ejection fraction. HFpEF tends to be more right ventricular failure. So if we can work together through the community heart failure team, the palliative care team, working together and developing knowledge and experience with each other, we can provide a much better service and much better care for these patients. And I would encourage you all to go out and make friends and see what's going on in your local area and find out when the heart failure MDT takes place. And just see if you can join it, even if you don't go every week. You know, you'll learn a lot from these meetings. We also have, as well as myself, we usually have 2 heart failure consultants, community heart failure team, and we have a renal physician as well, which is also very, very helpful. My top tips would be to let the patient set the agenda for consultation, because it's not always just about breathlessness. Don't use oxygen for breathless management in heart failure unless they've got really low oxygen saturations, and then think about why that might be. Have they got pulmonary edema? Have they got untreated COPD or non-optimized management of COPD? Have they got pleural effusion? You need to be thinking about what else might be going on. Remember the non-pharmacological management of breathlessness, because as we all know, every drug has side effects. And if ever I'm asked for advice about a heart failure patient, I will always want to know what's their pulse, what's their blood pressure, what's their heart rate, what's their renal function, and what's their function like, before I would suggest making any changes. It's always good to review medication, but don't rush it. You know, there is no rush. And whenever possible, consult with a heart failure nurse specialist or with a cardiologist if you can access one. And remember that deprescribing is as important as prescribing, and I know Roz will definitely agree with me on that. And, you know, that's the other thing about IV iron. A lot of the patients who have heart failure will be on oral iron, and if you give them IV, it means you can stop the IV iron, which means they're less likely to have diarrhea or nausea or constipation or whatever side effects they usually get with their intravenous iron, with their oral iron, sorry. What we have to remember is then in heart failure, beta blockers, ACE inhibitors, and spironolactone improve prognosis as well as symptom control. So you have to be careful which drug you stop first. A lot of our patients will be on anti-anginals, and I do reduce and sometimes stop those, especially if they haven't had any angina for a long time, because often the patients are fairly immobile by the time they get to see me. So if they're not doing as much, then they're less likely to get angina. Always make sure they've got a GTN spray available, and if you reduce them, then they need to be reviewed to make sure they haven't got more angina. You have to be very cautious about stopping beta blockers. And if you do plan to stop them, do it gradually and in consultation with cardiologists. I've had a few conversations recently because we've had patients who have been really symptomatic from the beta blockers, high dose Soltalol, because they've had episodes of VT and they feel absolutely wretched. They are massively fatigued, really cold all the time. And I approach the cardiologist to talk about reducing the Soltalol, and they're like, well, be on your head if they go into VF. So it's like, okay, we'll leave that one alone then, shall we? But always worth checking whether there might be another alternative, whether they could use amiodarone or something like that as an alternative to the beta blocker. When patients look as though they're moving in to the last 6 months of life, then I stop statins all the time. A lot of people are on calcium and vitamin D supplements. They're often on bisphosphonates, they're on iron, they're on folate, and then the vitamin supplements. I had a conversation during the MDT last week where I suggested that we should stop iron, folate, vitamin B12, calcium and vitamin D, and statin, and the heart failure nurse went, and that was all documented as part of the MDT discussion. And the heart failure nurse went back to the GP and refused to stop anything. So I felt really good about that. So there we are. I was too frightened to stop anything. Devices. I could give a whole other lecture on devices. It's very complicated. There are a number of different types of devices. So you've got the straightforward permanent pacemaker for heart block. You've got the CRT-Ds, which is that they're put in for heart failure for patients with an ejection fraction of less than 35%, with left bundle branch block and a prolonged QRS, because they are seen to be at higher risk of VF or VT. And the way a CRT works is that it coordinates the right and left ventricle to work synchronously. Patients got left bundle branch block, it slows down the electrical impulse to the left side of the heart. So you get the right, then the left, the right, then the left, and the heart is much more efficient if it's pumping synchronously. So a CRT actually resynchronizes the beating of the heart and makes the heart much more efficient. For those where defibrillation would not be appropriate, then they can have a CRT-P. And then the ICDs for those who don't have heart failure, and it's more about management of arrhythmias. But we need to remember that about 20% of patients who have an active ICD in place when they're dying receive a shock, and it's not very nice. So it's not just like a little jolt like that. And so we had a patient who died in Watford in A&E. And as he was dying, he was unconscious. His device was firing. He was literally sitting up off the trolley, and his family were absolutely distraught. Patients have described this as like being kicked in the chest by a horse. It's a really, really powerful shock that they receive. So I've just been involved in writing a SOP. We had an ICD deactivation policy in Watford that I wrote with one of the cardiologists, Phil Moore, and now we have gone on to write a SOP for deactivation of devices in the community, which means now the cardiac physiologist from Watford can go out to deactivate devices at a patient's home, in hospices, or wherever it needs to be done. So that is now in place, and East and North Hertfordshire are also launching a similar SOPs. Having said that, we should always try to do this preemptively when a patient can go up to the hospital and have the device deactivated. And the other thing to say, it is always the choice. The patients can choose not to have the device deactivated. You do have to be a little bit careful, because you don't want to be having a discussion about deactivation of ICD if they had a shock last week, because that's not going to go well. All right, so you have to choose your moment. I'll rattle through this very quickly. So this is a sort of a composite patient, if you like, an 84-year-old guy who had severe heart failure with an ejection fraction of 23%, had an active CRTD in place. He suffered atrial fibrillation, COPD, non-insulin dependent diabetes, renal impairment, gout, peripheral vascular disease, had had previous CVAs, and had had numerous falls. He'd had 3 admissions to hospital in the previous 6 months, 2 for decompensated heart failure, 1 with an infective exacerbation of COPD, and there had been a general significant decline in the last 6 months. There was an element of cognitive impairment. His CRTD had never fired. That was the list of medication when he first came to me, and this was actually before we started the IV iron service, and you can see he was on ferrous sulfate, 200 milligrams 3 times a day. And of course, what we know is a lot of our patients who have renal impairment are anemic because of that renal impairment, and I have a number of patients who are on intravenous iron supplemented by EPO. So we did a review of medication. His main issues at the time of referral were nausea, fatigue, achy legs, postural hypotension, constipation and diarrhea intermittently. That's because of the Movicol. He was breathless on exertion. He was fed up with a number of drugs. He had too many hospital appointments. He was frustrated in not being able to do things that he wanted to do. His blood pressure was 95/55. He had no peripheral edema. His pulse was a bit slow at 48. His U&E showed normal sodium and potassium. He had an eGFR of 50, which isn't bad actually for a heart failure patient. His LFTs were consistent with hepatic congestion. He had a raised BNP. Sugars were okay, as was his HbA1c. But boy, oh boy, at what cost? He had 3 different hospital consultants seeing him from cardiology and a heart failure nurse. He was living on the border between Hertfordshire and Buckinghamshire. We had 2 hospital consultants seeing him about his COPD with a CT chest book and pulmonary function tests, and an arm's length respiratory nurse specialist helping to manage him. He got gout, so he was being investigated by rheumatology and being seen in follow-up clinics. He was having vascular investigations for his peripheral vascular disease. He was under a diabetes specialist clinic, and he was under renal. So we reduced his bisoprolol because he was bradycardic. We stopped his ezetimibe. He had been on edoxaban for atrial fibrillation, and when he had been a bit of a drinker as well, so we were worried about the risk of falls. But if ever you talk to a cardiologist about, or a stroke consultant about stopping anticoagulation in falling elderly patients, they will always tell you that they need to be anticoagulated, because the risk of having a stroke in AF is higher than the risk of having a subdural following fall. We titrated up the allopurin according to renal function. We stopped the lansoprazole once his prednisolone for his gout had been stopped. We stopped the Movicol. Oh, I hate Movicol. Can I tell you how much I hate Movicol? It's such a popular drug with hospital consultants and GPs. It's vile. And it's 125, I think, mils of liquid you have to take when you're on a fluid restriction of 1.5 litres. That's cruel. It's also got a high sodium load as well. Sodium picosulfate, laxative of the day. So just bear that in mind. It's really small volumes. It's a liquid. You can use it at 2.5 to 5 mils, and often that will be enough. Sometimes you have to put a bit of senna in there as well. Because of his hypotension, we reduced the Entresto dose. We rationalised the hospital appointment. So I went through with him which ones were the most important ones to him, and then I contacted all the others and said, we need to say goodbye. And they were all happy with that. I checked his bloods. I had an advanced care planning discussion. We interrogated his device and deactivated his ICD. And then as the chest CT and pulmonary function tests were already booked, we let those go ahead, but then got him discharged following that. Skip over that. I'm sure you'll know about advanced care planning, so I'm not going to dwell on that. I think one of the key things is that you always need to know the indication for each individual drug, so you know which ones you can go for first. Warfarin, I mean, you can't use the DOACs for metallic valves. That still has to be warfarin. The DOACs aren't licensed for metallic valves. Are the beta blockers for angina? Are they rate control? Is it for heart failure? If it's for heart failure, I would reduce the dose. The other ones you have to be a bit more careful with. And gradually wean off the medicines, and it's important that the patient gets reviewed. Okay. So the last thing that I would say is that with the whole device issue, when you're doing advanced care planning, it is possible to have a DNA CPR in place, even if the patient has an active ICD, because of course, what can happen is the ICDs will shock them out of a shockable rhythm. So if they've got VF, it will shock them out of it. But if a patient goes into a systole or PEA, then the device won't work. And what we don't want is people to be doing CPR in that situation, because it's not a reversible cause. So an ICD will shock a patient out of a reversible cause for cardiac arrest, and we need to make sure that we're not jumping up and down on someone's chest if it's not a reversible cause. I hope that's